कतऽ जाइ छी? डैडी शक्ल दिखाओ ना।
कुछ बोला नहीं है, म्यूट करके रखो।
वाह, दिख गए। रुको मम्मी को बुलाते हैं, कैमरा ऑन रखना। डैडी खोलिए, कैमरा खोलिए। डैडी डैडी खोलिए खोलिए खोलिए।
आपने बोला कि 20 का 20 वेटेड का ये प्लान था, प्रपोज था। 20 वेटेड
गुड आफ्टरनून सर। अनम्यूट करो सर, अनम्यूट।
म्यूट कर दिया, अब कर दिया। क्या हाल
हाँ
है?
हाँ बोलो। बस बढ़िया सर।
कहाँ से बोल रहे हो?
मैं क्लिनिक में बैठा हूँ सर।
अच्छा अच्छा, तो क्लिनिक में कैप लगा के बैठते हो क्या?
नहीं 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 सर।
तो वैसे ही।
ऐसे ही सर, हॉस्पिटल हॉस्पिटल से आया था तो आते ही सीधे नीचे आ गया।
अच्छा अच्छा, गुड गुड,
हम्म।
चलो अच्छा है।
एक मिनट देखता हूँ सर, कितने लोग बात करूँ, चालू करें सर।
हाँ
आपकी आपकी बात हो गई है ना आनंद से?
हाँ, हो गई, उसको भेज भी दिया। मैंने कहा कोई डिफिकल्टी होगी तो आप चला देना, वैसे चल जाएगा।
हाँ ठीक। ठीक है सर, फिर तो कोई दिक्कत नहीं। स्टार्ट कर लेते हैं सर, दो चार पीछे आगे
हाँ
पीछे होते रहते हैं तो फिर कोई।
हाँ बिल्कुल, अपन चालू कर देते हैं।
ठीक सर, थैंक यू। So, good afternoon, everybody, and I welcome you all again for another very important class in this continuation of the certificate course for diabetes, which is being held by the Indian College of Physicians. And you have attended almost six classes previously, and this one is quite important. It's on microvascular complications of diabetes, and it will be taken by one of the very senior most endocrinologists of the country and of Rajasthan, the ex-head of the department at SMS Medical College, Dr. Prakash Keshwani sir. He is an eminent endocrinologist, and he was a professor, an ex-HOD, and now working at NIMS University. And is a leading practitioner in Rajasthan and has a vast experience in diabetes. So I hope that you all will be benefited by the knowledge and the experience which sir is going to share with us. And if there are any questions or queries, I think they can be taken up or clarified by sir after we finish the class. So I request Dr. Keshwani sir to initiate the class.
Thank you, Dr. Puneet. Thank you very much for nice introduction. A very good afternoon to all of you. At the outset, I shall like to thank Dr. Puneet for giving me this opportunity to be with you all in this afternoon. We shall be discussing today certain important aspects about the mm, microvascular complications, mm, microvascular complications of the diabetes. Yeah, captions, those share. So we know that diabetes is quite a common disease as on today, and a big number of complications are produced by the diabetes.
आ गया सर, स्क्रीन आ गया, प्रेजेंटेशन खोल लीजिए।
हाँ बस एक मिनट खुलता है।
यस।
Big number of complications. Is it okay, Dr. Puneet?
हाँ, it's perfect sir, perfect.
So a big number of
Yes, sir.
complications
Okay,
are
sir.
produced by the diabetes, and today we'll be discussing important aspects about the microvascular complications of the diabetes. Coming over to epidemiology of type 2 diabetes. This is from the IDF Atlas 2021, and at that time, prevalence of diabetes was supposed to be 537 millions across the world. And today, diabetes has come out as a global emergency, with Southeast Asia and India being one of the major contributors. And we are expecting more than 150 million diabetics by the year 2045, with an increase of 68% in the prevalence of the diabetes. These are the data from our own country study, ICMR India Diabetes, published in 2023. The weighted prevalence of diabetes in India is 11.4%, and the overall weighted prevalence of pre-diabetes is 15.3%. Diabetes, we know that creates a number of complications which can be acute metabolic complications like diabetic ketoacidosis or non-ketotic hyperosmolar coma. While there are a big number of chronic complications which can be the non-vascular or the vascular which are again categorized into microvascular and macrovascular complications. Diabetes is associated with significant microvascular complications, and that are mainly retinopathy, neuropathy, and nephropathy. Diabetic retinopathy has come out the most common cause of blindness in working age adults in developed countries. And at the same time, nephropathy has also come out as an important cause of renal failure. And it's the most important is if we manage this diabetic nephropathic patients in the initial stages at the time of the microalbuminuria, we will be able to control the advanced nephropathy to a large extent. Neuropathy again is the most common microvascular complication. It may manifest in different ways and can be difficult to manage. Prevention and reduction in progression of microvascular complications requires intensive management of glucose. That is the most important. And along with it, blood pressure control and the lipid control. If we are able to manage all these three parameters, we can avoid or delay the microvascular complications to quite some extent. Discussing these one by one. Diabetes neuropathy. It develops because of the hyperglycemia, which damages the peripheral nerves. And it is described as presence of symptoms and or signs of peripheral nerve dysfunction in diabetic after exclusion of other causes. So the diabetic neuropathy is a diagnosis of exclusion. If there is no other cause, then we label it as a diabetic neuropathy. WHO defines it as a disease characterized by a progressive loss of nerve fibers, leading to sensory loss, foot ulceration, and amputation. These are coming out to prevalence of the diabetic neuropathy. ICMR India suggests that the prevalence of diabetes is more than 10 crores, and approximately 50% of the patients with diabetes develop neuropathy at some or other time. And the prevalence of peripheral neuropathy in diabetic patients has been reported varying from 10 to 32%. Cardiac autonomic neuropathy is the most common complication of diabetes. The prevalence of autonomic diabetic neuropathy is approximately 31 to 73%. So we see that at least half of the patients of diabetes develop one or the other neuropathy at some time. And the most common is diabetic peripheral neuropathy. It's a frequent complication of diabetes and is associated with significant morbidity and mortality. It's an important risk factor for ulcer and amputation. It also impairs the quality of life. Here we can see the nerve fiber from a healthy person, the vasa nervorum, white pattern, and we can see the healthy myelinated and unmyelinated nerve fibers. While on the diagram on the right-hand side, we can see the vasa nervorum partially occluded, there's a decreased blood flow, and there's a damaged myelinated and unmyelinated nerve fiber. We can see the axon from a metabolically healthy individual, pink-colored axon, which seems to be healthy, surrounded by the myelin sheath. While on the right-hand side, we see that axon is damaged, and further, the myelin sheath is broken up at many of the places. Normally, the axon is surrounded by myelin sheath, which we can see in the diagram, the green color. With the development of neuropathy, there's loss of the myelin sheath. The axons are denuded, and they are damaged also. With the further progression, more and more myelin sheath is lost, and axons are damaged. And this leads to abnormal electrical signal transduction. In the left-hand side, we see electrical impulse, electrical conduction through a normal nerve fiber, while on the right-hand side, there's a damaged myelin sheath. The electrical signals are abnormal. That is how the pathological changes occurs in the peripheral nerves and how does it causes altered signals. The causes or risk factors for peripheral neuropathy include metabolic factors such as high blood glucose, most important, the long duration of diabetes, and possibly low level of insulin. So the primary culprit is hyperglycemia. And in addition to it, abnormal lipid profile, damage to blood vessels leading to local ischemia, oxidative stress and production of advanced glycosylated end products. Smoking and alcohol both have a very hazardous role effect on the nerves. Obesity has also come out as an important risk factor for peripheral neuropathy. Taller is the person, more is the chances of development of peripheral neuropathy. Autoimmune factors and genetic susceptibility are also important. When we talk of pathogenesis, primarily it is the hyperglycemia, causing an increased extracellular protein glycation, AGE and RAGE formation, increased intracellular glucose in nerve vascular tissues, and microvascular injury. This leads to nerve dysfunction and death of nerve fibers. While we talk of pathogenesis, a number of factors are important. Genetic factors have an important role. An earlier familial clustering analysis showed history of diabetic neuropathy in a family increased 2.2-fold lifetime risk of developing diabetic neuropathy. Earlier GWAS study reported 11.5 to 6% risk of single nucleotide polymorphism, heritability of the diabetic neuropathic pain. The other important is, or rather we can say most important is hyperglycemia. Hyperglycemia is injurious to health. It facilitates excessive generation of reactive oxygen species. It facilitates the production of the AGEs and receptors for AGEs and leads to oxidative stress and injury. Microcirculation is a decreased blood flow to the peripheral nerves in diabetes because the various growth factors like PEGF, nerve growth factor, and angiopoietins are decreased in presence of diabetes. And these factors are important as they promote the formation and development of the blood vessels. So blood vessels are affected in diabetes, leads to the local ischemia in the nerves. Various neurotropic factors, nerve growth factor, IGF-1 and 2, neurotropin 93, have been found to be reduced in patients with the diabetes, and that can be viewed as a contributing factor to the development of diabetic neuropathy. Immune system plays a role, particularly in patients with a proximal neuropathy and with a more marked neuropathy. Coming over to the symptoms, symptoms can be categorized into two categories. One is the positive symptoms, others is the negative symptoms. Positive symptoms include pain and paresthesia, burning sensations, Nike-like sensations, electrical sensations, or sensation of walking on carpets. While the patient may complain with the sensory loss, he says that he is not able to feel the ground or chappals. He says that patient is the foot looks like that is it's sleep. So these are the symptoms, positive symptoms and negative symptoms developed because of the peripheral neuropathy. Early symptoms of peripheral neuropathy are tingling, pinpricking, burning, and vibration. They usually start in the toes and fingertips, expands proximally over a time in a stocking and blow pattern. Sensation to stimuli such as vibration, pinprick, temperature, and monofilament testing all tends to decrease in the same pattern over time. The signs or symptoms of the peripheral neuropathy. The symptoms because of the large myelinated nerve fiber include numbness, tingling, and poor balance. And this can be observed by examining ankle reflex, vibration perception, and 10-gram monofilament sensation. Small nerve fiber symptoms include pain, burning, electric sensation, stabbing, hyperalgesia, and allodynia. And they can be tested clinically by thermal discrimination and pinprick sensation. We can test peripheral neuropathy with the microfilament, vibration test, pinprick test, mild touch, thermal test, or the joint positions. Diagnosis of peripheral neuropathy can be made traditionally by examination, by the touch, pinprick, vibration, sensation, temperature, monofilament, pressure sensation, and ankle reflex. And they are sufficient to diagnose peripheral neuropathy. Electrophysiological studies are usually not required in most of the cases. The standard electrophysiological methods include NCV. They are being used for diagnosis and to see the progression. They may not prove useful for diagnosing early small fiber disease. And most of the time, traditional classical clinical examination is sufficient. Newer methods include skin punch biopsy and immunohistochemical staining for peripheral nerves. Mean dendritic length and intraepidermal nerve fiber density can be quantified easily. And we can see the cornea and we can find out the nerve directly by the microscope. Their differential diagnoses include metabolic diseases like that of the thyroid and kidney, systemic diseases like vasculitis, paraproteinemia, amyloidosis, infectious diseases, inflammatory, and deficiency of vitamin B12, pyridoxine, thiamine, and tocopherol. What are the complications of peripheral neuropathy? Around 15 to 20% of patients with peripheral neuropathy are at risk of foot ulceration and gangrene. They are at risk for frequent burns. They also develop neuroarthropathy or the charcot foot. They are predisposed for frequent falls and fractures. They have a 15-fold increased risk of lower limb amputation. So these are the complications which are develops because of the peripheral neuropathy. The approach to treatment includes diagnosis, followed by the treatment. That includes treatment of the neuropathy and neuro symptoms as the treatment for symptoms like that of the pain. The management of peripheral neuropathy includes non-pharmacological measures as well as the pharmacological measures. Non-pharmacological measures, also called as disease-modifying treatment. They include weight management, physical exercise, cessation of smoking, stopping alcohol, and prevention or correction of complications. As good diabetic control alone may not limit prevention or progression of diabetic peripheral neuropathy, disease-modifying treatment may help. DMT are important as they alter the natural history of disease. Weight reduction. Obesity has come out as the second biggest metabolic risk factor for peripheral neuropathy. Weight reduction by medical and surgical methods have been found to have a beneficial effect. Exercise has been found to have any beneficial effect. A number of trials have confirmed by improvement in the intraepidermal nerve fiber density, cutaneous nerve regenerative capacity, and intradermal nerve fiber branching. So many of the studies have shown that these lifestyle modification in the terms of aerobic exercise, resistance or strengthening exercise, balance exercise, anti-sedentary behavior, and diet modification. These lifestyle modifications, along with the cessation of smoking and alcohol, help a lot as far as problem of peripheral neuropathy is concerned. Pharmacological treatment of the peripheral neuropathy include the most important is anti-diabetic treatment. The glucose should be in a good control range. That helps a lot. Other is control of the lipid profile. We will not go in detail of these because they are the general measure for all the complication and management of the diabetes. Others include antioxidants, symptomatic therapy, pain management, and prevention or correction of complication. These pharmacological options include aldose reductase inhibitors. ARIs reduces the flux of glucose through polyol pathway, inhibiting tissue accumulation of sorbitol and fructose. A number of drugs have been studied with equivocal results. Ipalistat is available to us for last around 10 years. Human IV immunoglobulin have shown improvement in distal neuropathy, possibly working as a immunomodulator. Gamma-linolenic acid. It preserves the prostaglandin E2 and is believed to increase the nerve blood. Aminoguanidine is an inhibitor of AGE's formation. Protein kinase C inhibitor are the other group of the drugs which are supposed to increase the blood flow. An inhibitor now named as ruboxytaurin has shown promising results. Alpha-lipoic acid acts as a thiol and is a potent antioxidant. So these are the drugs which may help in managing peripheral neuropathy. So we see that the disease-modifying agents, exercise, weight management, stopping alcohol, good control of diabetes, good control of lipid abnormalities, and many of these drugs may help in the treating this neuropathy. The other important thing for the peripheral neuropathy is management of pain. Pain in peripheral neuropathy tends to be multifactorial in origin. This makes difficult to treat, as consideration must be given to all causative agents. But unfortunately, addressing all causative agents is not easy and can be categorized as non-pharmacological measures, pharmacological measures, and other physical measures. Non-pharmacological measures include blood glucose control, reduction of weight, smoking cessation, anti-lipid treatment, antioxidant, exercises, and physical activity. The pharmacological agents include antidepressants. They are found to be effective and often considered as first-line drugs in the treatment. Tricyclic antidepressants ameliorate pain and are being used for a long time. Other group of drugs is anticonvulsants. They act on calcium channels and tends to have a good outcome in management of peripheral neuropathy. And as such, tends to be recommended among this class of treatment. Gabapentin is usually touted as first line for painful neuropathy. Pregabalin is another drug which is used in the treatment of peripheral neuropathy. Tramadol, which can be used either alone or in the combination with acetaminophen. And it inhibits both noradrenaline and serotonin reuptake within the spinal cord. These are the drugs which can be used for the painful neuropathy. There certain drugs can be used for the topical application that includes capsaicin, topical nitrite, local gabapentin, and local lignocaine are being also used for the topical treatment for painful neuropathies. Other physical therapies like that of acupuncture, percutaneous nerve stimulation, static magnetic field therapy, and low-intensity laser therapy, monochromatic infrared light, and electrical spinal cord stimulation. These are the modalities which have been tried and have been studied with equivocal results. So neuropathy in type 2 diabetic patient, we can summarize as neuropathy is a common microvascular complication, increases the risk for gangrene, ulceration, and amputation. It's usually difficult to treat. Good control on glucose and lipids along with cessation of smoking and alcohol helps. Pain and positive symptoms are improved with lifestyle measures and pharmacological agents, while sensory loss is difficult to cover. The next microvascular complication, which is important, is nephropathy, high blood pressure, and high blood glucose levels causes damage to the kidneys. Diabetic nephropathy is a syndrome characterized by the presence of pathological quantities of urinary albumin excretion, diabetes glomerular lesions, and loss of glomerular filtration rate in diabetics. Kidney disease is a frequent diabetic complication. This can be present in around 30 to 40% of the patients. And once a patient has diabetic kidney disease, there's a very high risk of developing of the cardiovascular diseases. If we see natural history of diabetic kidney disease, it's initially the hyperglycemia, leads to the increased perfusion, increased GFR, but this hyperglycemia later on causes cellular injury. This GFR is progressively reduced. Initially, there's microalbuminuria, followed by the macro or gross albuminuria and elevation of the creatinine and decreased GFR. Hypertension is usually present in patients with a diabetic kidney disease. The causes, the CKD in diabetic patient can be because of the DKD, diabetic kidney disease, but at the same time, other causes of the CKD are to be kept in mind, that are hypertension, renovascular causes, and other kidney diseases. There are mechanistic links between the prediabetes, diabetes, and end-stage kidney disease. The chronic hyperglycemia leads to the changes in the hemodynamics, leads to the inflammation, oxidative stress, apoptosis, and mitochondrial dysfunction in mitophagy. That leads to the diabetic nephropathy. There are structural changes in the glomerulus. There is increase in the basement. Right-hand side, we can see the thickness of the basement membranes is increased. There is mesangial cell proliferation, podocytes and food processes are damaged, and there's damage to the endothelial cells of the glomerular capillaries. That there are changes in the glomerulus. This is the first one is the normal glomerulus, and it's followed by the diffuse mesangial expansion. Later on, there's nodularity and mesangiolisis. Typical KW lesions are developed later on. There's capillary dilatation and microaneurysm, and at the end, obsolescent glomerulus or the totally distorted glomerulus, which are not able to produce any filtration. So we see that once the significant disease is formed, there it is usually irreversible. So early detection is important for the nephropathy. All patients of the type 1 after 5 years of the diagnosis, and all patients with type 2, right from the time of diagnosis, should be screened. And annually thereafter, if it comes normal. Normal ranges of the urinary albumin creatinine ratio is less than 30. We should calculate eGFR. If it is less than 60, again it is considered abnormal or presence of diabetic kidney disease. A big number of biomarkers in addition to the albumin can also be observed, which predicts the diabetic kidney disease, which includes cystatin C, alpha-1 microglobulin, beta alpha-2 microglobulin. There are markers for the glomerulus. There are markers for the tubule as well as the loop of Henle. So, whom to screen? All patients with the type 2 diabetes at the diagnosis, type 1, yearly starting after 5 years of the diagnosis. If spot urinary albumin creatinine ratio is more than 30, it is positive. eGFR is less than 60, it is positive. What if it comes to be positive? Confirm, repeat, and if it comes to be positive, start evidence-based treatment. What defines CKD diagnosis? Persistent urinary albumin creatinine ratio of more than 30 and persistent eGFR of less than 60. So we have to go for multidisciplinary approach for the managing these patients. Multidisciplinary education, management of the blood pressure, management of the diabetes. And these are the guidelines of the ADA 2025 for the management of the diabetes. And if there is CKD, they recommend for the SGLT2 inhibitor the first drug, followed by the GLP-1 receptor agonist. Guidelines include BP should be less than 130, blood pressure should be controlled with the AC inhibitors or ARBs. If urinary albumin creatinine ratio is present, we should start with the AC inhibitors, and drug of choice for these patients is SGLT2 inhibitors. While managing, we have to moderate protein restriction to delay the onset of uremic symptoms. It should be restricted to 0.6 to 0.7 gram per kilogram daily. We should recommend for low salt 4 to 6 grams sodium chloride to optimize blood pressure control. Phosphate restriction should be started early in the CKD, and potassium restriction should also be made. The drug of choice for these patients is the SGLT2 inhibitors, followed by the GLP-1 agonists. The KDIGO recommendation include the management of patients with CKD, healthy diet, lifestyle modification by exercise, cessation of smoking, and weight management. First line drug is SGLT2 inhibitors, followed by GLP-1 receptor agonists. All these patients should be put on the RAS inhibitors and followed by, if required, non-steroidal MRAs like that of finerenone. Another drug like the dihydropyridine CCB like the cilindipine should be used. What are the drugs? So we can see SGLT2 inhibitors have all the benefits if we start in patients with diabetes to prevent or to manage diabetic kidney disease, followed by the GLP-1 receptor agonist. If we see historical aspects on showing CKD progression associated with the type 2 diabetes, as early as 1982, there were no specific therapy for the CKD. By 1995, a number of trials like the captopril trial, all these were present, which suggested that AC inhibitors may help. And as on today or 2022, there is a Credence trial, TAPA CKD trial, and Fidelio trial. Suggest that we have a good number of the drugs are there, and we can see there was profound decline of the kidney functions. Kidney functions are now better managed with the availability of the SGLT2 inhibitors and other drugs like the MRAs and the AC inhibitors or ARBs. To summarize with diabetes, a decade in type 2 diabetes, advanced CKD is a high-risk clinical entity with high morbidity and mortality. CKD doubles the risk of cardiovascular events and deaths in patients with type 2 diabetes. It is never too late to improve glycemic control, but strategy is different. CKD stage should be considered when choosing an anti-diabetic therapy, avoiding hypoglycemia. Many changes in treatment are needed, making enhanced management challenging. GLP-1 receptor agonist and SGLT2 are the drug of choice, which manage CKD and at the same time other cardiovascular risk factors. MRAs have come out as another good class of the drug which can slow the progression of the nephropathy. BP control has more role as compared to that of other important microvascular complication is diabetic retinopathy. High blood glucose along with the high blood pressure and high lipid levels can affect the retina and leads to development of diabetic retinopathy. It is a microvascular disorder occurring due to long-term effects of diabetes, leading to vision-threatening damage to the retina, eventually leading to blindness. Most common, it's a most severe complication out of all ocular disorder caused by uncontrolled diabetes. So retinopathy is an important complication of the diabetic patients and most common cause of severe vision loss in adults of working age group. In the Western world, it has come out the most common cause for the blindness. When we talk of epidemiology, around 35% of diabetic patients develop some degree of retinopathy. Prevalence varies from 77% to the type 1 to 25% in a type 2. The global annual incidence of diabetic retinopathy has been reported between 2.2 to 12.7. The data from our own country, Union Health Ministry, first National Diabetes and Diabetic Retinopathy Survey reports Indian prevalence of diabetic retinopathy is 16.9%. Prevalence of sight-threatening diabetic retinopathy is 3.6%. It's higher in urban as compared to rural India. There are certain risk factors for the development of diabetic retinopathy. These can be categorized into three: non-modifiable risk factors, modifiable risk factors, and newer risk factors. Non-modifiable risk factors are puberty, pregnancy. These are the two stages where there is flare of retinopathy because of changes in the vascular needs of the body as well as the hormonal milieu of the body. Another non-modifiable risk factor is duration of diabetes. Modifiable risk factors are hypertension, obesity, dyslipidemia, poor glycemic control, and nephropathy. So all the patients with the diabetes should be managed for all these things right from beginning to avoid development of retinopathy. The newer risk factors include inflammation, apolipoproteins, hormonal influences, particularly after leptins are deposited, vitamin D, oxidative stress. So we can see that this is the hyperglycemia, which is the main culprit leading to retinal blood flow abnormalities, leads to the vascular occlusions. Growth factors are affected and leads to the vascular cell death. Basement membrane thickening occurs, which all leads to the retinal hypoxia. Says increase secretion of the various growth factors like that of VEGF, the placental growth factor, and pigment epithelial derived growth factors. That leads to the retinal neovascularization. Now coming over to the classification. This can be categorized mainly into the two: non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy further can be categorized as mild, moderate, or severe. This staging is important, one, for the diagnostics. Secondly, for detecting progression. Thirdly, for the monitoring treatment effectiveness and guiding treatment selection. The classification of diabetic retinopathy also helps in seeing further severity. In mild non-proliferative diabetic retinopathy, there are only microhemorrhages. In moderate non-proliferative diabetic retinopathy, more than just microhemorrhages, but it's less than the severe non-proliferative diabetic retinopathy. Severe non-NPDR is either there are 4 quadrants, each with severe intravitreal hemorrhages or microhemorrhagism, or 2 quadrants with the definite venous feeding, or 1 quadrant with the moderate intraretinal microvascular anomalies. Proliferative diabetic retinopathy can be characterized with a neovascularization, which can be present at the retina, iris, or angle, or the vitreous or pre-retinal hemorrhage, or the retinal detachment. While evaluating these patients, we should go for the proper history taking, but that includes duration of diabetes, type of diabetes, past glycemic control by seeing the HbA1c and the previous record, medications with which the patient has gone, associated systemic disorders like obesity, kidney disease, hypertension, pregnancy, dyslipidemia. Large proportion of patients with diabetic retinopathy might be asymptomatic in the early stages and might be discovered incidentally on fundus examination. As the disease progresses, following symptoms might be seen. One is the blood vision, distorted vision, floaters, flashes, partial or total loss of vision, poor night vision, and impaired color vision. All these can be observed in patients with retinopathy. Again, majority of the patients in initial stages are asymptomatic. So the screening is recommended. All patients with the type 2, right from the time of diagnosis, and type 1, after 5 years of the diagnosis of diabetes, must go for the detailed retinal examination by an ophthalmologist. Particularly all female type 1 or type 2 diabetic patients, when planning for pregnancy, should go for the retinal examination, and during pregnancy in the each trimester should go for the retinal examination. And which must refer to an experienced ophthalmologist in case of diabetic macular edema or moderate or worse non-proliferative diabetic retinopathy or any proliferative diabetic retinopathy. There's a class A recommendation for this. Panretinal laser photocoagulation therapy should be done in the proliferative diabetic retinopathy. This is where there is again class A recommendation for this. Coming over to management, non-proliferative retinopathy, we have to assure patient, we have to make them understand that at this stage, good control of diabetes, BP, and lipids is required. Moderate non-proliferative diabetic retinopathy, again, we have to convince patient for the good glycemic control, regular examination. If a patient has severe non-proliferative diabetic retinopathy, pan-retinal photocoagulation is required, and we must refer them to a qualified ophthalmologist. While in the patient with the proliferative diabetic retinopathy, urgent pan-retinal photocoagulation is recommended. Patients with the macular edema, we should go for the intravitreal anti-VEGF injections that can help in reducing macular edema and can save the vision. So patients with diabetic retinopathy and macular edema, pan-retinal photocoagulation, we should go for all patients with severe proliferative diabetic retinopathy. Focal laser photocoagulations is sometimes recommended, and sometimes these patients, if there's a persistent macular edema, these patients should go for the injections followed by the photocoagulation, and sometimes intravitreal injections of the corticosteroids are required. We can see once there are proliferative changes for macular edema, the treatment becomes difficult and is not always fruitful. So we should think of preventing diabetic retinopathy and at a primary stage by regular screening, and if it develops, we should prevent for developing go to the proliferative retinopathy or macular edema. To summarize with, diabetes eye disease can blind patients but can be prevented. Detect disease through training, screening, and good clinical examination. Stage the disease accurately to understand the risk of vision loss. We must work holistically, manage diabetes, and treat the eyes aggressively. We must work with the low vision services to support patients who have lost vision. So we can see that all these 3 microvascular complications are important, can cause life-threatening problem, affects the vision, can affect the longevity, can cause so many other problems. So we should try to manage diabetes right from the beginning. We must screen regularly for the before development of these retinopathy changes so that we can prevent blindness or end stage nephropathy. The last, I will like you, thank you all for the patient listening. Thank you very much. So then I can find a comment from the Dr. R.P. Parikh, relation of semaglutide with the to the blindness. Yes, all GLP-1 receptor agonist treatment have been found to have 2 cases of retinopathy and the blindness. The cause for this blindness has not been related with the GLP-1 receptor agonist, but the literature suggests that there is evidence few patients have developed retinopathy. What is the cause? We do not. Any other questions? Maximum dose of gabapentin we go in clinical practice for diabetic neuropathy. Yes, up to 900 milligrams many of the times is required, but at the same time, addition of antidepressant like amitriptyline can help for further increase of the dose. But 900 milligrams we can give easy. Other is initial treatment of diabetic neuropathy. Will we use ipalistate or lipoic acid preparation? Yes. Ipalistate, a number of trials are there. It's available in the market also. Lipoic acid, again, is useful. And ipalistate usually we prescribe along with the pregabalin or gabalin. The combination pills are also available. And till we find a clinical improvement for the pain, we usually prescribe this drug, but because of the cost of the pregabalin and gabalin, we have to think of withdrawing drug as soon as patients have relief of it. Can you? This is Dr. Kansara. What is the average duration of diabetic retinopathy and diabetic nephropathy to occur? Okay, diabetic nephropathy usually do not occur until 5 years after development of diabetes. So any patient where we are sure, like that of type 1 diabetic patients develop nephropathy before 5 years, don't think it is a diabetic kidney disease. Look for some other causes. But for type 2 diabetic patients, we cannot say like this. There may be pre-existing diabetes for a very long time. Patient with itching as a manifestation of neuropathy, how to treat, sir? Okay, these patients again can be treated with the low doses of gabapentin. Many of the times we have done, and of course, antihistaminic like that of the levocetirizine can be prescribed, but they usually do not help. And many of the patients with severe hyperglycemia have severe itching. That is because of the irritation of nerve endings, because of the high glucose in the intracellular part. And that leads to the intense itching. And good glycemic control can help in these patients. And many patients present with a dry mouth. How to treat them? The simple way is only to give sips of water. Nothing is going to help. Initial treatment of diabetic neuropathy. Again, the good control of the diabetes with the good control of the lipids and stop smoking, stop alcohol. Alcohol itself can cause peripheral neuropathy. So we have to be cautious for alcohol. And of course, supplements like that of vitamin B12 if needed. And ipalistate can be, theoretically we can give. And once a patient has painful neuropathy, then other drugs we have to. Any other questions? I think I could find a good number of responses. Even in normotensive patient, we use ACE inhibitor. Yes, if a patient, even if it is normotensive, there's urinary albumin excretion of more than 30, don't forget to start ACE inhibitors or ARBs. Will we use aldactone also in normotensive patients with albuminuria? Yes, it can be given, but the first drug recommended for this is ACE inhibitors or ARBs, change the antidiabetics, and if it is still progressing to the nephropathy, and we see the gross albuminuria, we can think of adding aldactone also. Can pre-diabetic patients have neuropathy? Yes. There are studies which show that at the time of the diagnosis of the type 2, when we go for the peripheral nerve examination, around it has been reported up to 30% of the patients in different studies who have some degree of neuropathy. Prediabetes can have. GFR till which we will give SGL2. Yes, up to 20 GFR we can give easily. Earlier we used to see to give up to the SGLT2 inhibitors up to the GFR 30, but now there are recommendation up to 20 we can give. Thank you, sir. Thank you, everybody, for patient listening to me and also participating and asking questions. Thank you very much.
Thank you, sir.
Okay. Bye. May I leave?
Yes, sir.
Can you hear me, sir? Hello? Hello?